Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Scylla Ball, and my guest today is Dr. Aleksandra Rachitskaya. Dr. Rachitskaya is a vitreoretinal surgeon and associate professor of ophthalmology at the Cleveland Clinic Cole Eye Institute. Dr. Rachitskaya, thank you so much for joining me today.
Well, it's my pleasure. It's great to be here with you today.
So let's jump into our case. This is a 70-year-old woman with a history of hypertension and type 2 diabetes who presents from her optometrist for changes in the macula. Her best corrected visual acuity is 20/25 in the right eye and 20/30 in the left eye. IOP and pupils are normal. She has 2+ NS in both eyes, and on dilated examination, you note many small macular drusen on both sides. Now, Dr. Rachitskaya, what additional questions would you want to ask in this patient to better understand their risk factors for things like AMD versus maybe diabetic macular changes?
Absolutely. This is probably a patient that we all see, maybe multiple times a day, right? So this is a very classic patient. And just like you mentioned, when you think of this patient, you kind of immediately, as you look at her history and her exam, you're starting to think, what's the contribution of diabetic retinopathy potentially, and what's the contribution of AMD? So in terms of diabetes, I would want to make sure she's under control. What's her historic control? Is she on insulin? Is she on the new medications such as GLP-1 receptor agonists and some of the newer medications that are out there? But focusing on macular degeneration, she's 70. She has, we haven't talked about imaging, but on the exam, she sounds like she has drusen. So I immediately have my list of questions that I will ask this patient. I will ask this patient if she has any known family history, because we know that there is a big genetic component to this. I will ask her if she has any history of current or remote smoking. That is another big factor that I consider. And then I ask all my patients about the history of several medications, because I want to make sure that I'm not missing any masqueraders. So all my trainees who are in my clinics, they know to ask about the use of Plaquenil or use of Pentosan, especially, if it's just drusen. That might not be as relevant, but if we see some atrophic changes, that becomes more pertinent. And of course, this patient is also 70, but I do ask, what was the first time they heard that they might have diagnosis of macular degeneration? Because sometimes we see patients who say, oh, when I was 40, somebody saw something, and that kind of clues you maybe this patient is just not a straightforward AMD patient. So those are my basic questions that I'm going to start, and I will look at their comorbidities, their hypercholesterolemia, their hypertension, to kind of paint for myself a full picture.
So you kind of already mentioned this, and that was very succinct, but when you're thinking about your differential for macular degeneration, you mentioned Plaquenil, you mentioned an earlier age. Are there other things that you should keep in the back of your mind when you see these macular changes that could potentially masquerade?
Absolutely. So when you think of the patients, when I think about AMD and the masqueraders, I kind of break it down. Our more standard early to intermediate AMD, right? In those patients, you think of such things as vitelliform, you think of maybe some IRDs, you think of pattern dystrophies. And then as you go into neovascular AMD, the masqueraders change as well, right? We start thinking, in this patient, could it be a contribution of diabetic macular edema? Could this patient have a central serous chororetinopathy? Could there be a potential for IPCV as another thing on the differential diagnosis? And then as we move on into geographic atrophy, which is, has gained so much attention recently, then my differential diagnosis changes once again. And I think once again about some of the inherited retinal diseases. I think of your Pentosan and Plaquenil toxicity. I think of zebras such as lord or something like that, because you really want to make sure, especially if you're thinking of potentially starting patients on treatment, you want to rule things out, things like Stargardt's, for instance. So I think your differential changes depending on where you are in terms of the presentation of AMD.
Absolutely. And at that point, for someone like me that's an anterior segment cornea person, I think I just send them over to you and hope that you figure it
I'll
out.
be happy to see them.
So, what are some of the distinguishing features of non-neovascular versus neovascular, or wet versus or dry versus wet AMD? Not really going too much into wet AMD for this podcast episode, but like right off the bat, what are the distinguishing features for the residents?
Yes, so I think we all start, even though it seems to probably residents that we look at pictures sometimes first, but as you're learning, the clinical exam is important, right? So you can see in patients who are neovascular, you might see hemorrhages, and it can be submacular hemorrhage, including subretinal or subarp hemorrhage. You can see fluid on the exam, and you can see the pigment epithelial detachments. So those are all kind of the signs that this patient might be in neovascular AMD. And of course, our workhorse, the OCT, that will really show you if there is some intraretinal, subretinal, or subarp fluid. A lot of times, as we look at the masqueraders, or we're trying to, cases that might be not so obvious. When we're looking at neovascular AMD, we look for also presence of CNV, choroidal neovascular membranes, and there's different types of CNV, and we can utilize such imaging modalities as OCT and geography to look for CNVs, both CNVs that are exudative and non-exudative, and then looking at our fluorescein angiography. I do believe there is still a role for fluorescein angiography when it comes to diagnosing neovascular AMD. The other thing that I'll point out is, as we think about macular degeneration, historically, right, we would talk about dry and wet. And that's what we've been telling the patients. That's what kind of been teaching. But now we have more and more attention drawn to advanced stage with geographic atrophy. And it's very important to actually look for signs of early geographic atrophy in what might appear just as intermediate age-related macular degeneration, because some of those lesions that are non-foveal you might not appreciate, but as they progress, they really affect the patient outcomes, and also they might change your treatment paradigm. So looking for those areas of atrophy both on OCT and on fundus autofluorescence and color photos is important. So clinical exam, of course, but we use a lot of ancillary imaging testing that help us both diagnose, decide on potential treatments, and also talk about future. Because I'll tell you, these patients with macular degeneration is a scary diagnosis for a lot of patients. And sometimes they go to see the optometrist, and they might have couple drusen, but they hear those words. And I've had so many patients who come to me and they have very minimal disease, which is fantastic, but they think they're going blind. So it's so essential to kind of educate, and also educate on the future for each particular patient.
It's so true. I mean, even me, I'm one of those people that behaves in a way that I shouldn't, but I did my 23andMe and it said that I had like two genes that increase my risk of AMD. And I immediately texted all of my retina friends and I'm
Right.
like, you need to figure this out because
Yep.
it's hard when it's you, when you're the patient, or when you're thinking about these things as the patient to kind of digest that information. But let's say this patient was in your clinic and you mentioned a lot of really valuable tests that you get or you would want in your AMD patients. What specifically would you want to see for sure in this patient coming in where on the clinical exam you see that drusen?
Yes, so I think for a baseline where I'm not very worried that this patient has neovascular AMD, I will get an OCT, and when I look at OCT, I look at all the layers, and I also look at the ANFAS image to look for areas of geographic atrophy. You can identify that on that ANFAS image, and I think it's a good. There's debate in the retinal community if you want to get autofluorescence and color fundus on that first visit. But I think somewhere early in the treatment and the follow-up of that patient, you might want to get that because it's very common that we find as geographic atrophy progresses, we if we look back, we see some early lesions, and so I think it's very beneficial to have that baseline information because as I tell my diabetic patients, as I tell my age related macular degeneration patients, these are chronic conditions and we are going to be chronic friends, so it's not a one-time visit, and some of those patients you don't see very often, so it's nice to see the progression and kind of correlate that with their visual complaints because there is a lot of research looking into how do we assess function, visual function in these patients, because BCVA is not always representative. So how do we assess function and kind of understand the symptoms that these patients experience?
I love what you said about this is a chronic condition and we're going to be chronic friends. That's a really beautiful way of putting it. You were able to get an OCT for this patient, and the OCT of the macula shows multiple discrete areas of elevation of the RPE consistent with drusen and kind of confirming the diagnosis of dry AMD. So, can you just explain a little bit more what drusen are and what you think about when you look at drusen? So, for example, what is a small or a large, a soft or a hard?
Yeah, I think there is more and more interest in different type of drusen, and we usually use the size and the amount of drusen to kind of differentiate it into early and intermediate AMD. The other things that I look for is pigment, and you can see it both on exam and also on OCT because I think it's a negative predictive factor in terms of the progression of the disease. And then we also look under subretinal drusenoid deposits, and that's another big factor of progression to geographic atrophy. So I think beyond just looking at your standard size of the drusen and looking at the vein coming off the optic nerve, I think those other factors are important, and sometimes it's very hard to see if it's subretinal drusenoid deposits, but the more you kind of look at it, the more you start recognizing that pattern as well. So I think in terms of predicting for patients their risk of progression to more advanced disease, those are the additional things that I look for on their imaging.
Okay, so we've mentioned geographic atrophy quite a bit, but how do you think about geographic atrophy? How do we distinguish kind of maybe more focal atrophy versus what would be called geographic atrophy? And then from a resident perspective, how do you generally expect to see the FA or the autofluorescence findings?
Yeah, absolutely. So, like I mentioned, I think we are recognizing more and more that even in patients that historically we might have classified as intermediate AMD, there might be some areas of geographic atrophy. The reason why it was not gaining so much attention is that previously there was no treatment for that, and the scope of this kind of discussion doesn't cover the treatments, the pros and cons, but there are treatments. There's FDA approved treatments for geographic atrophy. So before there was no treatment, so we probably didn't focus on that as much, and most of the areas of GA usually don't start in the fovea. It's very late that there's foveal involvement, so you have extrafoveal areas that if you just get your just one line or a couple line OCT, you're not going to catch that. So we that's why that unfast imaging is important. You can use OCT, and there's several publications looking how you can identify on the unfast imaging the areas of GA. And the standard kind of classic way is fundus autofluorescence. Now, fundus autofluorescence might be tricky to get. Not every office, especially satellite offices, might have the machine, or it's not as it's a little, the light is brighter, so it's not the most comfortable test for the patient. So, and if you have media opacity, you might not get the best quality image. The geographic atrophy, there's different patterns when we look at fundus autofluorescence, and different kind of risk of progression. For instance, if the classic thinking is diffuse trickling, just how it kind of the pattern is the most likely to progress. The important thing, I think, for residents to identify that you might have multifocal lesions, so it's not only one lesion but multiple lesions, and the larger the area of the borders, GA grows at the border, so the more lesions you have, the more borders you have, and so you're more likely to progress. And the way the GA progresses, it tends to kind of surround the fovea. It starts as a horseshoe, and then it goes into the donut, and then there's foveal involvement in majority of cases. Not everybody progresses in the same manner. But before, and the vision will drop significantly once there is foveal involvement. But it's very interesting because patients come a lot, and they say, my vision is poor. My vision is poor, but I'm told I'm 20/20. And it is, both of those statements are true, because when you check them on your standard visual acuity with Snellen visual acuity, you're going to get 20/20 because you have high contrast when environment where they're reading one letter at a time. But because of the scotomas or the blind spots that are created by geographic atrophy, the patient's quality of vision is extremely poor. And there's all these ways we're trying to find to kind of assess their vision, different contrasts, or low luminance, visual acuity, all this types of assessments. There's still no gold standard, but I think what becomes important in clinic is actually acknowledging the patient and saying, you are correct, because it's kind of simple things sometimes that we forget. We're so focused, on disease and kind of imaging, but telling the patient that literally that you're not crazy, you are correct, even though you're 20/20, your vision is not the normal 20/20. And you'll be surprised how many patients I've had who said, thank you, I didn't do anything. I just acknowledged that they're right, and they say thank you because I thought I was losing it. I thought something was wrong with me. And one patient with GA told me, I feel trapped in my vision. And I said, what do you mean? And she said, I feel trapped because I have quote unquote good vision, but I cannot see. And it really kind of brought it home to me, that experience of a patient who repeatedly gets told, and it's true, right? You're 20/20, but yet she cannot function with that 20/20 vision. So I think GA is truly still an unmet need, because even with the new treatments, there's no way to stop it or reverse it. So hopefully we'll have more options for our patients as we have clinical trials and research in that area.
It's so true. Most people, not even just patients, but people just want to feel understood and know that their doctor is listening to them and know that they are supporting them. So I think it's so important with these GA patients, but just with our patients in general, to have that relationship where we understand what they're going through. Even if we can't personally, we understand and we're there for them.
Yep, I totally agree.
So, switching gears a little bit here, what is AREDS and how does it guide your management of AMD?
So ARIDS is basically, a number of vitamins and minerals that have been studied extensively. In fact, I'm a big believer in ARIDS, and there's now 10-year data showing that use of ARIDS 2 slows down the progression to more advanced stages of the disease. And so I really want all my patients who with intermediate AMD or worse to be on ARIDS. There's actually some interesting new data that's been presented at the retinal meetings showing that it might slow down the progression of GA growth as well. So that's still, it's not necessarily something that's been studied in large trials, but there's some hints at that. So I have, the question becomes sometimes, well, you have the patient who now has GA. Should they continue taking the vitamins? And my answer is yes. And so ARIDS, I think, is essential. And in addition, so my kind of spiel or my conversation with the patients in terms of what can I do, right? Now you have the diagnosis. Now you told me that my symptoms are true, and you told me that there's potential treatments, but I'm still very scared and I want to do everything possible. So my usual conversation is, there's things we can control and things we cannot control. So it's age related macular degeneration, so it's related to the passage of time. And I never tell patients it's related to age because I had once a trainee who told the patient that their disease is related to their age, and the patient was so upset because they told them that they were old. The patient, granted, was 80 years old, but so I always tell, it's related to time, and it's called age-related macular degeneration, and then I say it's also genetics. So two things we have no control over as much as we would like to. So what can you control? So ARIDS2, that plays a big role. And then there's also studies that shown that Mediterranean diet actually can result in prevention and decreased rate of progression. So I highly recommend that. Sunglasses, and then making sure that patients do not smoke and also don't minimize secondhand smoke exposure. So those things I highlight, as well as increased level of activity, exercise, and it seems kind of obvious almost, those kind of recommendation who shouldn't be using sunglasses, but I always tell trainees that sometimes when we say the most obvious things, those resonate the most and might actually result in behavior change. And the patients, especially if it's something concrete that they can do and modify their environment. So those are my usual recommendations as we see patients, just like you described in this case.
You mentioned intermediate or advanced stage AMD, and I know AREDS has its 4-point grading system, but how do you kind of think about staging the AMD? Obviously, not getting into the neovascular patients, but kind of in these types of patients.
Yes, I get asked that question a lot because sometimes I have patients who have very early stages. They have small drusen, but they also might be scared, or they might have a family history of somebody turning wet and requiring injections. So my usual explanation is, if we look at data, you you are ARIDS2 candidate if you have intermediate AMD or worse. But the issue is, and I explain to patients is, we'll never have a study where patients who have a strong family history or patients who have early AMD started on ARIDS, because to see the difference, you need to have a huge study with very, very long term follow up. So it's not that it's not that it doesn't matter. It probably, the risk of progression is just so small in that cohort, we will never have the answer, because a lot of patients want to be on ARIDS, and the attitude, anything that I can do to help my eyes. I usually don't recommend ARIDS for those type of patients. I usually recommend more other modifications, as I mentioned, and age appropriate vitamins. So I usually don't start those patients. I kind of fall, in terms of my recommendation, I go more evidence based.
And when you're looking at them clinically, How would you like say we were to see this patient in clinic, what would qualify as intermediate AMD versus early stage? Do you generally look at the size of the drusen, or do you look at other features, other clinical features, just so that the residents know how they can diagnose
Oh,
this?
absolutely. Yeah. So I look at the size of the drusen. So you want to compare the size to half of the vein size, the number of drusen. You want to have multiple drusen, and then I look for pigmentary changes. So if they have any pigmentary changes, that immediately takes them over. And the other eye. So if the other eye has advanced disease, neovascular or GA, those patients I would start on AREDS 2 as well.
Okay, great. And you were also mentioning that even if a patient has GA, now we continue them on AREDS because there are studies that show that it's important to continue. So that's really great to know. I guess the other thing is, you mentioned AREDS 2 versus traditional AREDS. Can you tell us a little bit about what changed with AREDS 2 because of what we looked at in the lung cancer risk for smokers?
Yeah, I really don't see any in my own practice. I don't see any role for AREDS one. It had beta carotene that potentially there is a higher risk of cancer in former smokers. So, and I don't even know if you can find non-AREDS2 formulation anymore. Maybe if you really try on Amazon or something. We have lutein and zeaxanthin as the ingredients that have been added, and that's kind of the standard of care. Sometimes I have patients who have GI upset with AREDS vitamins, and that's probably the biggest complaint that I hear. And you can usually it's related to zinc, so you can recommend taking the vitamins, modify when you take it in relationship to your food intake. And there's actually formulations that don't have zinc, so that's sometimes an option for some of the patients who there's some patients who truly have significant GI upset and cannot tolerate AREDS to just the formulation as is with zinc.
That's good to know. That it's the zinc component that causes the GI upset, which I don't know that I realized. So going back to our patient, you provided beautiful counseling advice for your patients. And if this patient had multiple small drusen, no intermediate drusen, and were thought to be early stage, you mentioned Mediterranean diet, UV protection. Do you have these patients do the Amsler grid testing at home? How often do you like to see these patients for follow up? Is there anything else that you would counsel this patient specifically?
So, if the patient is early stage, like you mentioned, I probably wouldn't have them do Amsler grid because the rate of conversion. We're looking for conversion to neovascular or exudative AMD, so the rate is very low, and so usually that applies more to intermediate or patients that I'm worried about, and it depends on the patient and where they're coming from. I feel a lot of times that early AMD can be followed by their general ophthalmologist or optometrist. But majority of patients, like I mentioned, patients who come to see a retina specialist, they're a little bit more concerned, and I usually see on them on an annual basis, and kind of follow them. The other thing that I do tell patients, especially male patients, is when it comes to Emsler grid, I highlight it a little bit more because majority of the female patients, if you think about it, close one of their eyes. For instance, when applying makeup, right? Male patients don't close their one eye usually for any reason, right? And so we've seen it time and time again when the patient, with AMD or a lot of other ocular conditions, white cataract, the patient comes in and they say, well, it happened yesterday, and you look and you're like, there's no way it happened yesterday. And because it's usually a non-dominant eye and the change is subtle, and then it's not recognized. So I explained the importance of the Emsler grid more as monitoring at home, and then ability to catch the change in your non-dominant eye, and that's the importance of doing it with each eye separately. Because sometimes I get the answer, of course I use Amsligrid, it's on my fridge, I look at it every day and with both eyes open. Well, that's probably is not going to achieve the goal that we're trying to do. There is also other monitoring. There's several apps. I usually don't use those because they haven't been studied extensively, but there's apps. And then there's a 4C device that's been used for intermediate AMD to monitor at home. It's interesting. The adoption has been kind of varied, and there's a lot of testing that's involved. And currently not utilized for non-neovascular MD, well, and for neovascular MD still in clinical kind of studies, is home OCT. So we'll see where that takes us, but it's probably going to be something that's going to become available in the very near future, more for neovascular AMD, not for non-neovascular AMD. So it's exciting, and I think there's just so much advancement. And the other thing that I think is very important to educate patients about, patients hear wet and they once again think it's kind of a death sentence, and we have so many options, so many fantastic options that we can preserve vision. I saw a patient the other day that I've been treating for 10 years, and the patient is in her 90s and she's 20/30, and she can function and read and be independent, and it's because we've been able to treat her. So it's a chronic condition, but it's a condition, especially if caught early, is a condition we can manage really well.
It's incredible. It's so exciting to hear about the future of medicine in general and to hear stories like this of 90-year-old patients. I had one patient in her 90s, an AMD patient when I was a resident, and she would come in full face of makeup, jewelry, high heels, walking by herself, no problems, and she would get her injections and walk out of there. And so it really is so inspiring to see patients like that. I remember I asked her, what's your secret? And she said, chocolate and never get married. And I was like,
I'm good on one of those.
yes, exactly, exactly. So I always love seeing those patients. So this was an incredible episode. Dr. Rachitskaya, thank you so much for joining us on the Pupil Pod.
Well, it's been such a pleasure. Thank you for having me. I appreciate it.
And thank you to those tuning in. See you next time on the Pupil Pod.